Hi, we're continuing in the series of videos for parents who have children with borderline disorders, and I was always really emphasizing this is not just adolescent children, but young adult children. Um, I wanted to talk about suicidality and threats made by the borderline child today. Um, the first thing I would say is that there's so many things in mental health that we are only just beginning to understand. And this is one of the areas where we have a great deal to learn. Um, there's very little predictability, there's not a lot of understanding. There's certain groups that have had spiked rates of suicide over the last decade, and yet in other areas we see groups have declined rates of suicide. So the first question is, at a very, very simple level, why do people kill themselves? And the simple answer is that people kill themselves because they have overwhelming psychological pain and they are unable to cope with their deep feelings of sadness, which are simply unbearable for them. There are very broadly two kinds of suicidal thoughts: passive and active. Passive suicidal thoughts are thoughts where the person would say to themselves, oh, I wonder what it would be like if I could sleep and sleep and sleep and not wake up so that my psychological pain would vanish. Because these people are suffering from deep feelings of hopeless despair and helpless sense of emotional pain. The other type are active suicidal thoughts, where the person doesn't passively think, but rather actively considers, for example, you know, there are ways to take my life. I could go in front of a major highway and simply walk on so a car traveling at a high speed can hit me. Um, I can go in front of a moving train. These are kinds of behaviors that have a very high likelihood of death. And of course, not to mention using a firearm so that the individual shoots themselves, often in the head. Um, Other kinds of suicidal ideation, which involve active issues, actually have a relatively low rate of success, including, of course, overdosing or using medications that are not prescribed. For various reasons, people usually become very ill, they don't follow through, they don't take enough medication, um, they're found in time, there are different reasons. But those are two broad ways to understand suicidality: passive suicidality and active suicidality. The only very great generalization I would say for the child who talks about this is that um, it should be taken very seriously. Now, many times when a person says they're going to hurt themselves or kill themselves, and they're really two different things, um, it needs to be taken very seriously, even though the person is probably not going to follow through. And yet, the best indicator, apparently, for completed suicides are individuals who have previously made an attempt to try to end their life. And the response from the parents should simply be, look, I have to really premise this with something very important. You're a good parent, you love your child, you're doing your best. This is a very difficult situation, and it's going to go on for not months, for years and years, and perhaps throughout um, the child's adulthood, even with good professional psychiatric and family and community supports. And the reality is that if someone really wants to take their own life, they will do it. And there are plenty of people who have been suicidal. They've been admitted, for example, to inpatient psychiatry so they can be contained to ensure that they're safe. And, days or weeks or months after getting out, they have it in the back of their mind to end their own life, and they'll do it. Um, so what I would say to parents or to anyone, any loved one that has a relative or friend saying this, take it very seriously, but approach it as with any other serious behavioral uh, or emotional or cognitive issue. of dysfunction presented by the borderline child, and that is set appropriate boundaries and say to the child, look, it sounds like you're really in a lot of pain. Perhaps you're very angry or disappointed. I really hear a deep sense of frustration. And you can even use the language of suicidality. You can say, look, it sounds like you feel hopeless, feelings of despair and deep psychological pain and helplessness, and it must be awful. But I want to tell you that when you tell me you're going to take your own life, I have to take it very seriously as a parent, or if I was a friend or anyone else. And I need to call someone in. We either have to go to the emergency room, perhaps 911 needs to be called now, or a very similar kind of very serious intervention so that the child knows that the child cannot just say that. Now, it's important to understand the difference between a threat that the child makes and a threat that is viable. The problem is if you're a parent or a friend or spouse or anybody, it's very difficult at times to distinguish between a viable threat which the child may follow through on and a non-viable threat that the child asserts for various reasons. The child may assert the threat because the child is attention seeking. The child may assert the threat because the child is trying to be coercive or manipulative in some way. The child may be making the threat because it's part and parcel of how that individual communicates with others. It's possible, and hopefully we'll get to this, that that child often catastrophizes. In other words, sometimes we see in borderlines, and I have this as one of the criteria in my book, they see situations in its worst possible light and the outcome of any particular situation in its worst possible light. And as a result, sometimes the individual will think of death or killing themselves and whatnot as something, as a reasonable outcome within that catastrophizing thinking. Once the child knows that every time that threat is made, whether truly viable and immediate and acute, or more generally ideational and passive, as I noted, they will all have the same response. I know some people listening will think, well, then the child may not say anything, and you may end up with the quiet borderline, and we talked about that in another video. Someone who's going to remain very quiet, internally deal with their issues. They won't externalize their anger, disappointment, fears, and anxieties, and so on. And that's possible, and it's a consideration. But nonetheless, when someone makes a threat that seems reasonable, and that, by the way, is very scary for the parent, very scary for siblings and other people in the home or friends, it needs to be taken seriously because, you don't want, God forbid, to not take it seriously one day and then, something does happen. It also reinforces, as I said, for the child, an understanding that there will be a consistent way that this matter is dealt with, so that the child won't use it as an attention-seeking behavior, so the child won't use it in the context of catastrophizing and so on. The child can use other forms of verbal threats or catastrophizing, but not this, because it's just too serious not to be taken at face value. When professionals need to be called in, as I said, this issue needs to be contextualized, explaining how often or when the child says it. And then appropriate measures would be taken with anybody with these kinds of thoughts, including perhaps appropriate psychiatric follow-up care, safety plans, and other people in the home should know about this. Just because someone says, I'm going to hurt myself, I'm going to kill myself over and over and over again, doesn't mean that it should be taken less seriously. in some ways it needs to be taken more seriously. That includes those threats that occur in the context of a specific reactive issue. So, for example, the child, has applied to a college, for example, that she absolutely wanted to get into for one reason or another and doesn't get in and says, "Oh, I'm going to kill myself." It's reactive. It's probably not something to be taken literally. But again, it's not your job to be able to adequately clinically distinguish between what's real and between what's not real. Suicidal uh, behaviors and gestures are very much related to self-mutilation. Self-mutilation occurs in many different forms. Most usually, it occurs with superficial cutting on the forearms and thighs, although it can happen in other places, with various kinds of sharp objects, including with razor blades. The large majority of the people who are engaging in self-damage, uh, particularly superficial self-damage to their body, even though it looks very scary because they're using perhaps a razor blade, as I said, rarely um, overlap that kind of superficial self-damage to the body with suicide. Suicide um, and self-damage also tend to be dynamically different. It's usually the case that with suicide, people, as I said, feel hopeless, overwhelming despair, and deep psychological helpless pain. And the pain is at such a high level that they would prefer to be dead as a means to negate that pain, um, because in that moment, in those hours, perhaps in those days or weeks when it's most serious, it does not seem reasonable that the pain will ever sufficiently abate to the point where the person can feel okay again. And so suicide seems like a reasonable alternative. With self-cutting and self-damaging acts, it seems to be that the individual is doing so for different reasons altogether. For example, the person may not have a sense of their own pain or understand their pain, and they cut themselves or harm themselves as a means to feel pain, and for some borderlines to feel something. In other words, sometimes borderlines feel so empty inside that they cut themselves in order to feel something. Others feel and assert that self-cutting, for example, alleviates psychological or emotional pain. There's also cultural issues involved. Um, I don't know what the stats are like now, I haven't seen them recently, but there was a time when self-cutting among teenagers, particularly girls, although it's not exclusively females, would self-cut because other girls would self-cut, and it was almost like a contagion, a social contagion, like with smoking or drinking. Um, Many of these individuals who would self-cut as teenagers would stop of their own accord in their late adolescence or early adulthood. It's not clear if they had outgrown it developmentally, or because as a social issue was no longer something that was seen with others in their peer group, or if they had emotional or psychological changes in their lives. It's not quite clear. Um, it also seems that many of the people who self-harm um, self-harm in a great deal of different ways, right? I mean, you can self-harm through risky sexual behaviors, risky use of alcohol, risky use of drugs, of going to places that are unsafe, such as parties in the middle of the night, in the middle of nowhere where there are obviously no security and you don't know anybody. Um, and it seems to be that these kinds of self-damaging and risky decisions um, generally appear as different phenomenon than passive and active suicidal ideation, although clearly there is probably some overlap. Um, there are also, highly risky behaviors that people engage in every day, but they're clearly not borderlines and they're clearly not trying to hurt themselves. And one, well-known example is rock climbing. Rock climbing is very dangerous. There are rock climbers that do so um, without any gear. They just climb of their own accord, including different structures, including buildings. Um, Clearly, that is a very dangerous endeavor. And yet, it's not clear that these individuals in any way actually want to take their own lives, or that in any way they really feel hopeless despair or psychological pain, or that in any way in other areas of their life they're self-damaging or even particularly impulsive or prone to risky behavior. Still, um, there's a general sense that all these things need to be seen or understood conceptually under the same rubric of self-harm, even though they may be in fact quite different phenomenon. In fact, I sometimes feel that some people who are suicidal, it's almost like there's like a genetic button or something within them. It's so specific. I wouldn't even necessarily understand some of these individuals within the context of major depressive disorder, because it seems as if they have a specific kind of button that um, gears them towards this specific kind of self damage, um, to the exclusion of other to the exclusion of other kinds of self harm, right? And it's curious, like, why, if someone really wants to hurt themselves, do they choose an endeavor that hurts themselves slowly over a long period? Or why would they not choose an endeavor, for example, that can be very dangerous in the immediate here and now, that would have a much higher likelihood of causing them much greater damage? And this occurs even within the same sub areas, for example, drugs and alcohol, right? I mean, you can drink over a 10, 20, 30, 40-year period and really damage yourself. But it may take a long time to kill yourself because you damage your liver or whatnot. Um, or you can use much stronger kinds of drugs over a much shorter period of time that are even much riskier as a means to damage yourself or even go in the direction of ending your life. It's not quite clear why individuals make these kinds of decisions. Um, for borderlines, threats of self harm and self mutilating gestures ultimately regulate emotions, alleviate feelings of emptiness, or provide relief against self hatred. It may allow for personal control. It may serve as a way to punish oneself for perceived wrongdoing, or it may serve to gain attention or to simply feel something. Many borderlines would just as soon be dead unless someone can really affirm their need to remain alive. So deep is their need for human recognition of their psychological and emotional issues and their psychological and emotional pain. Um, I think that's all I'm going to say about that. The only other thing that I would um, consider for this video is that it can be very frightening for others in the family, not just adult parents, but siblings, and sometimes even extended family members and friends, to see this and become aware of this. Um, there's so many things that are talked about openly, and then there's so many things that are not talked about openly. And self-harm and suicide is really it's almost a taboo thing even today. And depending on the age of the other family members in the home, there needs to be a real understanding and psychoeducation piece so that other siblings can recognize what is going on and the seriousness. The adjunct to this is that, well, parents clearly want to look out for signs of self-harm and suicidality. Um, Sometimes the best people to recognize these things are siblings and peers. And if it's the case that siblings and peers may be more immediately aware of what the family member is doing, what the borderline adolescent is doing, then that person may be the best source of eyes and ears to ensure that the borderline remains safe and that things are reported to the parents. It shouldn't become a thing like, the other siblings are tattletaling, don't misunderstand me, but these are potentially extremely serious issues that could be life and death, at the level of life and death, and they need to be regarded as such. Um, I think that's all I'm going to say about that. The last thing I think I just want to conclude with is that um, it's a bit of a mystery, impulsivity and um, thoughts of self-harm, because if the borderline engages in healthy and safe activities such as hobbies, and we see this very often, that bring the individual enjoyment and solace and a personal sense of accomplishment, then why would the borderline also need to engage in impulsive high-risk activities which jeopardizes safety and which may ultimately negate his ability to engage in the enjoyable, healthy, and safe activities? And as I said, I think in some people, there's almost like a suicidal switch. It's almost like a specific, I don't want to use the word protein, but a specific um, mechanism that needs to be understood and attacked pharmacologically, through therapy, through family support, and so on, which is really distinguishable from normal impulsivity. Um, Finally, with regard to catastrophizing, um, catastrophizing for the borderline is a huge thing. It's how they may see the world. It's how they may justify or employ their cognitive dysregulation. Um, Usually, catastrophic thinking involves ruminating about worst case scenarios, worst case outcomes, even when there is not sufficient evidence to suggest that any catastrophe is at hand. Um, and it's important to understand this because it can create a self-fulfilling prophecy of doom for the individual. It can be a paralyzing issue, which can cause crises. In catastrophic thinking, the borderline essentially convinces himself of the worst possible outcome by using reason, at least his own subjective reason, utilizing every possible negative issue and outcome while neglecting what seems to be very reasonable and possible outcomes going the other way. Um, the borderline's thinking, therefore, can be very parochial, very narrow, and non-inclusive. Catastrophic thinking is often time-specific, occurring in the here and now, because when fears are considered with flexible thinking over many hours or days, the worst-case scenario may indeed be one conclusion, but thoughtful consideration will lead to the possibility of many other outcomes as well, including positive outcomes or even survival strategies, making the worst-case scenario seem unnecessary or untenable. Catastrophic thinking and similar cognitive dysfunction often provoke responses from others so that the borderline can gain a sense of security and validation. And looping back to what we started with, about our talk about suicidality and threats of suicidality, it's often about the need for validation, the need to feel secure. It's a cry for help, as cliche as that sounds. It's the borderline's attempt to convey their deep sense of pain and need and fears of abandonment. But ultimately, whether it's more general catastrophic thinking or a specific kind of impulsive self harm, such as superficial cutting on the body, or a specific threat of self harm, such as I'm going to kill myself, I'm going to go throw myself in front of a train, the parent needs to act in an appropriate way, just like any other caregiver, to ensure that either 911 is called or an emergency hospital is visited for an evaluation, so that the individual understands that such thinking has consequences. It has consequences for the person making the threats. It has consequences for the listener, who is, obviously concerned and frightened and wants to ensure that the individual is safe. And the only way to do that is to take these threats seriously, while still doing your very best to understand the context of how these threats are being made.